Welcome to the fourth set of notes in Unit 8 Clinical Psychology. These will cover depressive disorder category as well as bipolar and related disorders. I do want to mention very quickly that these two categories, depressive disorder as well as bipolar disorder, used to be under one umbrella term in the DSM known as mood disorders, but of course they are now two separate categories in the DSM-5, and we will talk about them separately within these sets of notes. All right, so major depressive disorder. I do want to start off with that depression, and I need to make sure you understand this, that depression is the common cold of psychological disorders. It is not unheard of for someone to catch a cold, just like it's not unheard of for someone to suffer from depression. And you can see that when we look at the statistics. Between 6 to 10% of US population is clinically depressed. And it is the number one reason people seek mental health services, even more than anxiety. Women are twice as likely as men to experience major depression. Approximately 1/4 or a quarter of all females will experience an episode of major depression at some point in their lives. Symptoms of major depressive disorder must last for 2 weeks without cause, meaning not a major loss, a death of a loved one, a breakup of a very long-term relationship. And for those who are grieving from a major loss, symptoms must last for 2 months. So this is to say that yes, you can be depressed from a major loss. It happens frequently, but the symptoms need to be longer lasting than if it's not caused by a major loss. Either depressed mood or loss of interest or pleasure in almost all activities. And I really want to stress that individuals who are suffering from a major depressive disorder is suffering from a loss of interest, something that they used to enjoy doing, they no longer enjoy. And another thing I want to bring up is that depression is not just feeling sad. There's some people who are like, oh, they felt sad, they were depressed. Depression is like not just a sad feeling. Okay, think back to the states of consciousness unit that we covered earlier this year, and think about when we talked about being in a depressed state, your mind being in a depressed state. It was slowed down. Right? Your central nervous system was slow. The peripheral nervous system was slow. The autonomic nervous system was slow. If they take a drug, a depressant drug, it's going to slow down those responses. And that is what a depressive disorder is doing. It is not them being sad. So, and to be diagnosed with major depressive disorder, they have to have 4 of the following: a marked weight gain or loss, constant sleeping problems, agitated or greatly slowed down behavior, fatigue, that is the body slowing down, the inability to think clearly, feelings of worthlessness, and frequent thoughts of death or suicide. In a major depressive disordered individual, on a PET scan, we would see a remarkable contrast in their brain activity. It would be a very slow brain activity. So causes of major depressive disorder. So once again, we're looking at the perspectives here. From a psychoanalytic perspective, what is causing MDD? Well, this is the losses, invoke memories of negative childhood experiences. So they've had a loss of some sort that now has resurfaced these negative childhood experiences that they may have repressed, or the feelings of unresolved anger towards their parents, that then leads them to develop these symptoms and a slowing down of their brain activity. The biological perspective is a lack or insufficient amount of neurotransmitters. Serotonin is the one to know. It's a lack of serotonin, so definitely star that, highlight that, underline it, whatever you need to do. When we talk about the cause of MDD, it's going to be a lack of serotonin, but it can also be an insufficient amount of norepinephrine or dopamine. And then your social cognitive cause, it'd be negative thoughts influence negative behaviors that influence the situation and in turn influence thought patterns. It's the depression cycle. They get in this cycle, negative thoughts, patterns, and influence the situation, and it's hard to break that cycle. So when we talk about the depression cycle, this is what we're talking about. It starts with a negative, stressful event. Something is stressful for them, pulls them out of that homeostasis. They then become pessimistic. They're ruminating on it, explanatory cycle. They are going over the causes, how they messed up, what's the issue. They can't stop thinking about this event, maybe how they messed up, the mistake they made. That then leads them to the depressed mood, and they become hopeless in the depressed state, and then hampers the way the individual thinks and acts. So cognitive behavioral changes here, and thus fuels personal rejection. And then, because they have this fuel of personal rejection, they go back into that negative, stressful event, and the whole cycle repeats itself again. The next disorder is persistent depressive disorder. It is formally known as dysthymia. You need to know both terms. Although less disabling, dysthymic disorder is marked by chronic low energy and poor self-esteem. It is seen as a more low-grade, longer-lasting depression. The next category we want to talk about is bipolar and related disorders. This is another category within the DSM-5. Bipolar disorder is formally called manic depressive disorder. These are the two aspects of bipolar. You will have a manic stage and then a depressive stage for it to be bipolar. And this disorder is marked by an alteration between the depression and mania, and that is the big signal that it is bipolar disorder. So depressive symptoms, they're gloomy, they're withdrawn, their inability to make decisions, tired, slowness of thought. The symptoms are very similar to major depressive disorder, but where it differs is in the manic symptoms. So then an individual who suffers from bipolar disorder will have this manic phase, and there's elation and euphoria. There's a desire for action. Got to go. They're hyperactive. They're kind of all over the place. They've got multiple ideas, and they're bursting forth with information and wanting to tackle major projects or do something creative. This is what you're going to see in that manic side of the bipolar disorder. Many great writers, poets, composers suffered from bipolar disorder. During their manic phases, their creativity surged, and their output of their chosen craft was exceptional, and then dropped off during their depressive phases, in which they did not have the energy to do the things that they once loved. And that makes sense when you think of what bipolar disorder actually is. Now, there are two types of bipolar disorder. There's bipolar 1. This experiences manic episodes and usually major depressive episodes. So you have very high highs and they have very low lows. And then bipolar 2, they experience mania to a lesser degree. Their highs are not as high. So this is going to be called hypomania. Most patients who experience hypomania do not see it as a problem, yet the people around them may be concerned about their erratic behavior. So at least 4 days of hypomania. And then you have cyclothymic disorder. And this is, they have the hypomania, so not the high, they've got the, a little lower of the mania, and the depressive symptoms for at least 2 years, yet symptoms do not constitute a full major depressive episode or mania. So now we're going to look at the causes of bipolar, or possible causes of bipolar disorder. The biological cause would be evidence of inherited predisposition is very strong. So 2/3 of those with this disorder have strong history of mood disorders, and appear to be some psychosocial factors in triggering new episodes or preventing them. So found that stressful events often triggered manic episodes. So they're in a stressful event, they all of a sudden they're like, I got to get this done, and it triggers them into this manic episode to be much more productive. And so that triggers it. And the problem is they can't control that. They just keep trying to outdo themselves, and they keep going higher and higher. So they get overexcited, and then they lose control of the situation, and they all of a sudden can't get all these balls that they're juggling in the air done. It ends in, they mess it up. They all of a sudden realize they're in deep trouble and trying to meet deadlines, and then that plunges them into a depressive state. So here's some PET scans that show the brain energy consumption that rises and falls within a manic and depressive episodes. You know, the two on the outer edges are the depressive state. You notice there is very little, if any, brain activity at all that goes to that depressive state of the brain. But then in the manic, it is very, very, active, and lots of things are firing at once. And, that goes into this burst of energy that they get. So again, it's not just about being sad or being happy. It is about the brain and the brain's activity, which hopefully these images are really driving home for you. That wraps up the fourth set of notes under Unit 8 Clinical Psychology. If you have any questions, please let me know. And don't forget, don't do anything too stupid. Bye, guys.